Welcome to Conversations on Healthcare. This week's guest is Dr. Eric Topol of the Scripps Translational Institute on the Omicron variant, boosters, and holiday travel concerns. Now, here's Mark Masselli and Margaret Flinter.
We're speaking today with Dr. Eric Topol, founder and director of the Scripps Research Translational Institute, renowned for his work in advancing digital health and personalized medicine. He previously led the Cleveland Clinic to the #1 ranking for cardiac care.
Dr. Topol continues to lend significant support to the National Institute of Health's All of Us Precision Medicine program, a program of great national significance. He's the author of more than 1,200 papers, several books, including The Patient Will See You Now. And he was once ranked by Modern Healthcare as the most influential physician executive in the United States. Dr. Topol, welcome back to Conversations on Healthcare today.
Thanks very much, Margaret and Mark. Good to be with you again.
That's great. And Dr. Topol, Omicron is dominating the pandemic news right now, and there's lots of unknowns. But last week you said there were lots of reasons for optimism that this is not some horrible situation that we're in. We know the data is coming in, and the data will drive our perceptions. But what do you say now?
Well, it's not the Doomsday variant, fortunately. I mean, we do know that there have been many people who've been vaccinated, exposed, infected with Omicron, and they're holding up well. We don't know of any yet, actually, who've been very ill. That's good. But the fact that it's getting into people who've been vaccinated, even with a booster, third shot, is, of course, disconcerting. I think the main property of Omicron that is disturbing and very concerning is that it has marked immune evasion, that it works around our recognition from the prior virus versions and from our vaccine immunity to some degree. Okay, and so that gives it an enhanced ability to spread. And that's what we're seeing, of course, not just in South Africa, but now we're seeing it with many super spreader events in Norway, in Denmark, in the UK, and a lot more to come. So it may well be on its way to becoming the dominant strain, taking over, displacing Delta. We'll have to see over time. But, you know, there's good and bad here. We have a new, very challenging variant that's mutation-laden like we've not seen before. That's giving our immune system a challenge. On the other hand, the vaccines we have, for the most part, are holding up reasonably well, and that's a good sign.
Well, you know, it's interesting, Dr. Topol, even in states with fairly robust vaccination rates, we're seeing increases in hospitalization, increases in deaths associated with the Delta variant, and yet, you know, the reports of Omicron seem to have spurred some more impetus on people's part to go get vaccinated in the first place. Do you think people are beginning to see that this is just something we're in for the long haul, and maybe some of the resistors are moving a little bit more towards accepting a vaccine?
I hope so. I sure hope so. We are dreadfully low in our vaccination rate. Ranking somewhere around 50th in the world as far as countries. Our 60% of the total population vaccinated is not going to get us very far. We've seen the likes of countries like Czech Republic and Hungary, which are at the same levels, that are in desperate shape right now. We've left ourselves terribly vulnerable. Also, because of the waning, we need to get our boosters up much higher than they are. We're lagging in that as well compared to many other countries. So we have a lot of work to do. And maybe the good part of Omicron, if there's any other good part, would be to help us get our immunity wall built more, both with respect to, number one, getting more vaccinations, and number two, getting those who have been vaccinated to maintain their full effectiveness.
You know, I'm wondering, as I think about what you've just said, I'm wondering if this is and we're still waiting on the Omicron data to come in over the next couple of weeks to really sort of solidify what scientists' view of this. Is this a good time for Americans to be traveling internationally? And I'm thinking about the holidays that are coming up. How should people deal with this, and what safeguards might they take? I'm wondering, would you travel internationally right now, or would you sort of wait this out until we get more information?
I wouldn't want to be on any long flights right now. We don't really have the systems in place to get maximized safety. Let me just expound a little bit. First of all, as already mentioned, Delta is out of control here. We have about 100,000 cases a day, and we're on the way up, back up, a second Delta surge in the US. So in this country, we have a lot of circulating Delta virus, which is, as you well know, hyper transmissible. It's really been a formidable foe. Now, you add to that, we don't have a rapid testing program set up well, such that if you go on a plane, and even if you knew everyone was fully vaccinated, which should be 3 shots if you're out by 6 months, you don't know at that moment in time whether they're a carrier. Mm-hmm. That is, they're going to have symptoms later in the flight or in the next day, as we saw on the flight from South Africa to Amsterdam.
Right.
So we don't, if we had those things, that is, the rapid testing that was done at the airport by everyone, that results were done in 5 minutes systematically, and we, had everybody who got on a plane that was vaccinated and masked and all those things. Yeah, we could do it safely, but we just don't have those systems in place. We know what to do, we just don't do it repeatedly.
Well, I'm hoping that we're beginning to, as a country, move closer to that widespread availability of rapid testing. And certainly in the community health center world, that seems to be happening much more. Put it in the hands of the patient, put it in the medicine chest of people at home to test when they need to do it. And we're hopeful that will continue to move forward. But I wanted to ask you about a tweet that you posted in August. It certainly caught my attention. And I think I'm quoting this accurately when you say there needs to be some truth telling about the reduced effectiveness of the messenger RNA vaccines versus symptomatic Delta infections. What were you meaning by that? And we were certainly out there convincing people to get the vaccine, it's effective. And that one sort of caught me a little bit off guard. What was your message there?
Well, it caught a lot of people off guard, and I got a lot of backlash about it. But frankly, it was a case of denial. So by August, we already had clear signs that the mRNA vaccines, particularly Pfizer, but also some data with Moderna, were losing their efficacy by 4 to 6 months. And that was against not just infections, but symptomatic infections, which is a bad sign, which is going to turn out in people who have increased risk, like over age 60, as it turned out to be over age 40, to have more hospitalizations and deaths. You knew it was going to happen, but there was denial because of 2 reasons. Number one, there was the issue that, we're trying to get our vaccinations up. So keep quiet because this is going to undermine the success of the campaign. Well, that's really stupid because you can do both. Get the truth out saying, you know what, you need to get vaccinated and you're probably going to need another shot once you get beyond 6 months. Just tell the truth from the get-go so you don't have to make stuff up later and look like you didn't tell the truth. The second thing is about global equity. We all want the entire species, near 8 billion people to get vaccinated, but we don't have enough vaccines in the low and middle income countries yet, like we should, particularly the continent of Africa. That doesn't mean we shouldn't press on and get that up to scale. We need to do both. But don't let the people who are protected become unprotected. That's not going to help anyone. And that's not going to help get control of the pandemic in the United States, where we've underutilized vaccines grossly. So I laid it out there. Turned out it was true. The signal was obvious. And it took months for some of these public health experts to now using Omicron as the excuse for why they are now recommending boosters for all adults. But sorry, the data was unequivocal.
Yeah.
And we had a randomized trial, by the way, of over 10,000 people who got the Pfizer vaccine with 2 shots and got a placebo versus 2 shots and a booster. And it showed very substantial restoration of efficacy, over 95%. That's fantastic. But that could have been predicted back in August. And by the way, that's why President Biden made an announcement in August. Okay. And he said, all adults are going to be able to get a booster shot and should get a booster shot. Then he had to walk it back because all the infighting at the CDC and FDA with the rogue scientists at the FDA. And, this is crazy stuff. We should all be looking at the data and we have a single voice, consistent voice. And we haven't had that in this country. We've got divisiveness even within our leadership.
Well, you're so right that data should be driving our policy, and we look forward to more transparency on the data that's out there. And it's great for you sharing that randomized clinical trial. Those are really the acid test for so much. I want to focus a little bit about the mRNA platform. The vaccine technology is being evaluated as a way to treat cancer, autoimmune diseases, and other conditions. I'm wondering if you're doing any research on this, and how do you see the mRNA technology advancing healthcare? It sounds too good to be true, but it's obviously had a long history over the last couple of decades in its development. Now it seems to be really ripe. Lots of investments going in terms of research. What are you seeing? What are you excited about this new not new, but new to the general public technology?
Well, to be clear, it's been a work in progress for 3 decades, right? And, I think Carrico and Weissman out of University of Pennsylvania deserve really the credit for that persistent work and the ability to give mRNA. And they figured out what needed to be done so it didn't evoke inflammation, preventing the mRNA from being able to be effective. So now, as you say, it opens up lots of possibilities. Our group at Scripps Research is particularly interested in, because we're in a pandemic, of getting this for pan-sarbecovirus vaccines. That is, so we won't have to worry about each Greek letter as they come along, and that we have a vaccine that works against all variants, all future variants in this family. That would be ideal, and I believe we'll get there. We could have gotten there potentially by now had we had a global consortium that was given the number one priority and the resources that were necessary. We have lots of different labs around the world that are working on this kind of in a redundant, isolated fashion. So as you say, though, other groups are working on it for heart disease, for all sorts of other conditions, including suppressing the immune system in autoimmune diseases and in cancer. So we'll see. I mean, there already is a triple vaccine working to get RSV, flu, and COVID all in one with mRNA. Lots of diverse potential, but obviously a lot of that excitement has to be validated in large clinical trials, and we haven't seen those yet.
Just to follow up on that, on the vaccine's efficacy, as you said, waned after a number of months. Are people working on just, I assume, on the modifications of the underlying, underlying structure of the vaccine, so it will have longer effect, or I assume that that's going on as well?
Well, there are some things that can be done, like the adjuvants and the other ways, part of the package of the vaccine, but it's predominantly the result of the virus itself. And the fact that the virus, when you are getting exposed to such a hypercontagious virus like Delta, as we've seen, that that's what it really was, a combination of time plus Delta. We were still dealing with the ancestral strain, probably our vaccines would have held up much better. We didn't see hardly any breakthroughs. They're very rare until we had time plus Delta. So, what we're dealing with is, as the virus evolves, it gets even more challenging. And it's this double hit of waning plus the evolving virus.
But Dr. Topol, I think this is such an important point. I'm going to stay on it for just a moment, if you don't mind. Are we really saying to people, and not unfamiliar to them, or at least parents and people in healthcare, that we're talking about a 3-part series, like if you have to get hepatitis B or the DTaP series that you give your kids, you just know it's a 3-part series standing up. And I think people kind of get 1, 2, got it 6 months later, get that third one, and then I might be good. Is that what you're saying, and who do we need to have come out with this? Is it CDC that really needs to weigh in on this at this point?
Well, I do think that, as I've posted, fully vaccinated should be 3 shots. 3 shots of all vaccines, except we don't have any data for J&J whether a 3rd shot will be useful. There aren't data. And for people who've had prior COVID, even 1 shot may be enough. Certainly not 3 is necessary. But for the rest of the vaccines and the rest of people who are relying on vaccination for their immunity, 3 shots is fully vaccinated. Already we have Israel that's recognized that for months, no less other countries that are coming to that conclusion. Just to reiterate, we knew when the COVID vaccines were developed that the 2 shots weren't going to be a lifetime vaccine. The only question that was right from the get-go was, would it be 1 year, 2 years? How much time could we eke out? Especially remember that these were done, the trials and the rollout, with very short spacing, 3 weeks for Pfizer, 4 weeks for Moderna, because we were in a crisis.
Yeah.
And that's not ideal. I mean, everyone recognized that if they were spaced longer, this would be better. And we now have data to substantiate that. So, I think the only thing that was a surprise was that we wound up at 6 months, 5-6 months, rather than, 1 or 2 years. But this is a 3-shot vaccine. And the question really is how durable that package is going to be over the years ahead. We'll have to see.
I want to go back to your statement about this is a worldwide pandemic and we're spaceship Earth. We're all on the same plane, if you will, and it can spread. And so thinking that we've gone through a number of variants, not all concerning, but what's out there waiting? I mean, I don't want to be a downer here in terms of this conversation, but in a fairly short time, we've got to something called Omicron that could be dangerous, but it was in part because we really haven't done this effort of vaccinating the whole world. And it doesn't look like, if I look out the next 12 months, there's the political will or united effort. What do we have to worry about out there? And are there things that might be things that we can't solve that arises in this era of pandemics? Well,
I think we do need to get cohesive in our efforts. And I mentioned we could have had potentially a pan-cervical virus vaccine done already into clinical trials had we had this real coalescence of our work, but we don't. And in so many things that we haven't yet gotten our act together. I mentioned the rapid test as another example. We just can do better. We've had 2 years to get our act together, and we still don't do it. And it's frustrating, really, because by now, what we're seeing with Omicron is like deja vu. Remember back in February 2020, oh, it's been found in this state. Oh, now it's found in that state. How many cases in this state? We have the same thing. We know it's in every state now, Omicron, but where is our contact tracing? Where is our quarantine and isolation capabilities? No less our systematic sequencing for breakthroughs, hospitalizations, people coming from international who are coming in with an infection. There's so many things we could do better. And you wonder, for at least the United States, is this a bureaucratic issue of our country? Why can't we move in the right direction? Obviously, we have a plague of misinformation and disinformation that's holding us back. But there again, we haven't had an aggressive counter to take that on and call these bad actors and organizations, call them out and put them in the hall of shame for the country to see. We haven't been doing that. We've been letting them just run amok, and that's really diminished our chance of getting these very high vaccination rates that we need.
Well, Dr. Topol, in all of this, there's a group of sufferers that I want to just call out right now, which is the folks who are really suffering with this long COVID syndrome and suffering greatly. I think we all agree. And I know that at Scripps, you've got a new research initiative underway looking at whether wearable devices might make a contribution to improving long-term symptom management, giving patients another tool to work with. Tell us a little bit about that. I think we all probably know somebody, patients or family members that are suffering from long COVID.
Well, thanks for bringing this out, because I think long COVID is one important area that's missed in the pandemic. It doesn't get nearly as much attention. And it may be as many as 10% of people who get infections are suffering in some way or other for some duration, some now from the early times of the origin of the pandemic. And I've had colleagues still today that are suffering with profound fatigue and lots of other symptoms, of course, including difficulty breathing or exercising. So Julia Vogel in our group is heading up a trial to try to coach people, that is trying to pulse oneself to have using up energy in a way that's more efficient. That's one tool that the various patient groups have found to be useful, trying to get some valid data. We also know things like that are out there, like whether vaccination helps in people who had long COVID or to prevent long COVID or other things that are out there dangling. And we don't have any therapies yet. We don't have anything that can help squash this symptom complex. And of course, we know it's a mosaic of many different symptoms, different in any given individual. So we have a lot of work to do for long COVID. And, fortunately, we're starting to see some trials, prospective work getting done, but we can't do enough because these people, too many of them are really substantially been affected adversely.
You talked about sort of a little reservation about maybe traveling on a plane long distance. I'm just thinking about the day-to-day work, about the effectiveness of masks. Obviously, people should get vaccinated, but what have we learned about properly fitted mask indoors where somebody else may have the virus, but you don't? What precautions should be people taking, and how important is just masking and washing your hands?
Well, the mask story is really important. And what we haven't done is get medical grade masks to everybody, which would really help a lot. Obviously, we might not be able to get N95 masks, for use throughout the pandemic to every American, but we certainly could do far better. We have never given out masks. In fact, I actually think that could help promote some unity by having, USA flag on the mask, and it's high grade, high quality. But as you say, it needs to be tight fitting. They have tremendous help and protection, no less are other maneuvers like physical distancing, ventilation, air filtration, all these things that we don't necessarily do, but could do. And we may need to do more to help counter not just the Delta surge that we're experiencing right now, who knows where that's going to take us, but also that when Omicron starts to get into the exponential phase, which obviously is still in the very early days now. So we have the tools to keep Omicron and any variant in check. We have them, but masks are an important part. Again, we have the people out there who are anti-science, anti-mask, anti-vaccines, trying to have mandates about not having masks, mandates about not having vaccine. This is incredible stuff. You can't just, you can't believe this is happening in a civilized country. It's amazing to me.
And just today's December 6th, when will we have the definitive word on Omicron in terms of the work that has to be done at by the scientist?
Well, I think the two biggest questions are not just if it's more immune evasive, but how much more. Beta was the variant with the most before. It's worse than beta. We just don't know how bad, because when we see the lab tests, hopefully late this week or early next week, they'll be coming from multiple labs. We'll quantify, and that'll give us an idea about how well our vaccines are going to hold up for neutralizing antibodies. And soon after that, we'll get the same kind of data for T cells. The other big question is, how contagious is it? How much more contagious is it than Delta? We don't know that yet. That's going to take epidemiologic studies. We're going to know that in the weeks ahead as well. So we'll get a much better readout on Omicron, gradually over the next few weeks. But it certainly doesn't look encouraging, except for the fact that the vaccines are holding up reasonably well against severe illness, and that's a very important sign.
We've been speaking today with Dr. Eric Topol, director of the Scripps Research Translational Institute. Follow his work at scripps.edu/translation, or follow him on Twitter at Eric Topol. Dr. Topol, we want to thank you again for your dedicated quest to gather and share reliable data and insights on this pandemic, and for joining us again on Conversations on Healthcare.
Thanks so much for having me again, Margaret and Mark. All the best to you.